This podcast provides general information, not a substitute for professional medical advice. Please consult your physician for personalized guidance.
Hello. Welcome back to Psych Rounds, a resident-run educational psychiatry podcast. I'm Dr. Tanner Hewitt, and while Dr. Bradley Miller is out today, I'm joined by our other co-host, Dr. Larry Way. Now, today we will be talking about the antipsychotic Clozapine, also known by its brand name, Clozaril. And who better to have on than the man who spearheaded the efforts to get Clozapine approved in the United States, with his monumental paper in 1988 titled Clozapine, the Treatment-Resistant Schizophrenic, a double-blind comparison with chlorpromazine. So I'd like to introduce Dr. John Kane, who completed medical school at NYU and residency training at Zucker Hillside Hospital, where he stayed on subsequently as chair of psychiatry for over 34 years. He's also done extensive research in the field and has nearly 900 scientific papers published in peer-reviewed journals. Now, Dr. Kane, is there anything else you'd like to say to introduce yourself?
Oh, thanks. I'm very pleased to be able to join you today and appreciate the opportunity to talk to some of your colleagues.
Thank you. Thank you for joining us. So, to quickly give our listeners a backstory on this medication to those who are not familiar, Clozapine is widely considered the first atypical antipsychotic. And in layman's terms, it's a fairly old medication first being synthesized in 1958. So really not all that much newer compared to something like chlorpromazine. Of note, it did not receive FDA approval in the United States until 30 plus years later in 1989. So why was there such a big gap in time from development to approval? Well, going over the history, Clozapine did receive approval in some European countries in the 1970s, but there were some problems that arose related to its propensity for causing agranulocytosis. Specifically, I believe there was a case in Finland which resulted in the death of over 8 patients. And so Clozapine's status in the United States became uncertain. So I was wondering what it was about Clozapine that made you, Dr. Kane, want to look back into this medication. And I was wondering if you could walk us through the history of how you published the paper and eventually helped get this medication approved in the United States.
Sure. Thanks for the question. So I had read some of the data that came out of Europe. As you mentioned, there were some countries that had approved the use of Clozapine. Professor Hippius in Germany had done a study in treatment-resistant patients. So I was aware of some of that work, and I was interested in the possibility that Clozapine could be at least studied in the United States. As you said, there were a series of deaths in Finland as a result of severe neutropenia. And that led the FDA to be extremely cautious about approving Clozapine. The company that at that point was manufacturing Clozapine was Sandoz, a Swiss pharmaceutical company. They did have some IND, some investigational new drug permissions for a few investigators in the United States to use Clozapine. And one of those investigators was a man named Nathan Kline in New York. What happened was Dr. Kline, I guess, had not been keeping up with the paperwork that was necessary to support his IND. Sandoz basically told him that they were no longer going to share permission to use the drug. And they asked me to take over his patients with the goal of actually getting them off Clozapine, because at that point, they did not think that Clozapine had a future in the U.S. So I was very young at that point. I had recently finished my residency. I've been in touch with the company. They were aware of me because I had expressed interest in Clozapine. And so I took over a group of patients that had been treated by this gentleman. And I did try to discontinue Clozapine in some of them, and with not very good results. We put them back on Clozapine. We're very, very impressed with the efficacy that it had in these people who were quite ill. we then had a conversation with the FDA and with the company about how much potential we thought that this drug had. The FDA said there really were not enough data on which to base an approval. But if we were to conduct a very well-designed and well-executed study that showed clozapine to be superior over available antipsychotic drugs in treatment-resistant patients, that they would consider approving it. And we met at that time with Paul Lieber, who was the head of the psychopharm drugs division at the Food and Drug Administration. And he participated very closely with us in the design of a study. And that was what became known as Study 30. And we worked very hard to design a study that we thought would obviously satisfy the FDA and be, credible in the field. It was a very conservative study. We required that patients have a lead-in prospective documentation of failure to respond to antipsychotic medication. Because what you see, if you look at the literature of studies in treatment-resistant schizophrenia, you often see a surprising amount of response even in the control condition. These were allegedly treatment-resistant patients, but when they go into a study, there's often a surprising amount of improvement. It's, akin to what we see with placebo in patients who are acutely psychotic. So we had a lead-in phase where patients had to be treated with haloperidol prospectively and continue to demonstrate a lack of response. And then they were randomly assigned to clozapine or chlorpromazine on a double-blind basis. And the study was successful. Many people were surprised that clozapine worked under that strict protocol, but it was successful. We published that paper in the archives, what was then called the Archives of General Psychiatry in 1988. Dr. Lieber, representing the FDA, as I said, had been involved in the design of that study. So I think the FDA was sympathetic because the study had been conducted with their guidance. The challenge, though, was the great concern that they had about monitoring patients for the development of agranulocytosis, which we now refer to as severe neutropenia. Because of the deaths in Finland, not a lot was known about the extent of that risk. And the FDA wanted to be sure there was some way to ensure that patients would have weekly blood tests, and that a policy was implemented of no blood, no drug. People had to have a blood test in order to have their prescription filled. And that there was a lot of controversy surrounding that, but it was executed. The plan worked. Ultimately, over the ensuing years, we realized that the risk of severe neutropenia could be managed much better. Currently, the estimates are that it's about 0.4%, and the related death rate is about 0.05%. So the death rate is very, very low. We are much better able to manage severe neutropenia when it does occur. So I think it's much less of a risk than it was in the late 1970s or early 1980s. So the package labeling still requires monitoring, weekly monitoring for the first 6 months, and then biweekly between month 6 and 12, and then monthly thereafter, but continuous. There's no cessation. Perhaps later in this conversation, we're going to talk about the recent FDA meeting on the REMS program. But I think everyone was very pleased to have a medication that the FDA had approved for the treatment of those patients who had failed to respond to first-line treatments. The problem has been, in all honesty, that clozapine continues to be grossly underutilized. And more than several decades later, it still is the only drug that has FDA approval for treatment-resistant patients, which is kind of a sad commentary on our inability to develop new medicines that are more effective. And ironically, we still don't really know how clozapine works. We know that it binds to a lot of different receptors in the brain. We used to say it was a dirty drug. Now we like to say it's a drug with a rich pharmacology. But the reality is we still don't understand how it works. The approval of Cobenfy, xanomeline plus trospium, M1, M4 agonist, has renewed interest in the muscarinic agonists and the role that they might play in facilitating treatment response, but a lot of unanswered questions there. But that's sorry if that was a long-winded answer to your question, but that's a little bit of the history of clozapine, and it is unusual in the sense that many people question the desirability of collaborating with pharmaceutical companies. That this is something that's not recommended to young academicians. The reality is that study would never have been funded by NIH. I think we were very fortunate to have a manufacturer that was interested in trying to develop a medicine that could work in that situation. Once it was approved and once we demonstrated that it did have superior efficacy, then NIMH started funding studies with clozapine. And so they have funded, a number of studies. But I don't think they would have funded that initial investigation. We really need to rely at times on the pharmaceutical industry to develop new treatments and provide the initial data going forward.
Well, thank you for going over that history. It was very, very helpful. And I will never say dirty drug ever again. Every drug is going to be a drug with rich pharmacology that binds to a lot of receptors. But you kind of already touched on some of this. You mentioned how for treatment-resistant psychosis in particular, clozapine is vastly more superior than the other antipsychotics such as haloperidol or chlorpromazine. And you talked about some of the muscarinic agonism, and we're not exactly sure how clozapine works, but are there any other guesses? So, for example, I hear a lot about its potential actions on glutamate receptors, things like that, especially because, of the antipsychotics, it's a very, very poor D2 blocker.
Yes, you're absolutely right. I honestly cannot comment, though, on the mechanism. I think we still have a lot of unknowns there. There are a number of hypotheses that have been suggested. To what extent the muscarinic agonism plays a role, we don't really know, in my opinion. So, with xanomeline and trospium, it will be interesting to see if that medicine works when other medicines have failed. We don't know yet. What we've seen so far are some very well conducted studies against placebo in acutely psychotic patients with good effect size. So we know that it works in acute psychosis. We know that it's a different mechanism of action, that it's muscarinic agonists rather than dopamine receptor antagonists. But whether or not that mechanism will provide superior efficacy in comparison to other drugs remains to be determined. There is a study underway where Cobenfy is the brand name. I prefer to use generic names. So xanomeline trospium is being added to other antipsychotic drugs in patients who have failed to respond adequately to those drugs. They may not meet criteria for treatment resistance, but they are patients who still have residual positive symptoms. So that's an adjunctive study. We expect that study to read out within the next few months, I think, and we'll see if that study is positive. It might suggest that xanomeline plus trospium might be helpful in patients who might be treatment resistant. So we'll have to see. There's a lot more work that needs to be done.
Yeah, absolutely. Now, Dr. Kane, I want to take just a brief moment. We touched on the severe neutropenia, which is one of the main things that's often tested on our board exams as young residents. But there's also things like weight gain, constipation, sialorrhea, decrease in seizure threshold, orthostatic hypotension, and even some reports of myocarditis. But specifically, I want to talk about constipation first, since this is one of the things that I run into. And I believe there are actually higher rates of death due to paralytic ileus rather than the severe neutropenia. So what are some ways in which we can combat some of these side effects?
Well, you're absolutely right. First, let me just comment in general that, yes, clozapine has a number of adverse effects, some of which are potentially fatal. Paralytic ileus is one of them. So gastric hypermotility is a serious concern. Pneumonia, aspiration pneumonia is another phenomenon that's associated with a death rate. So there are other causes of death associated with clozapine side effects besides severe neutropenia. But yet, severe neutropenia gets perhaps more attention because it's easier to do a blood test and measure neutrophils than it is to sort of monitor all of these other things, which I think is a mistake. I think we need to focus more attention, as you said, on monitoring for some of these other potentially serious adverse effects. Despite all of this, though, it's fascinating that when you look at mortality rates among schizophrenia patients being treated with antipsychotic drugs, the mortality rates among patients receiving clozapine are significantly lower than those receiving other medications. So that, in a way, that's counterintuitive. It just shows that the advantages of clozapine really do outweigh some of the concerns about these potentially serious adverse effects. As far as constipation goes, it is one of the most common adverse effects. So most patients are going to experience some degree of constipation as a result of clozapine. And as you suggested, it can lead to paralytic ileus, which is potentially fatal. So I think it's probably advisable that anybody who's starting on clozapine also first to be screened to understand whether they're already having gastric hypomotility and rule out other medicines that might be contributing to that. Those medicines should be discontinued if at all possible. Patients should be advised on hydration and exercise and things like that. But even with that, patients should probably be started on medications to counter the constipating effects of clozapine. And by that, stool softener, an osmotic agent, and potentially a stimulant, and even all three together to try to prevent severe constipation. So as you said, I think it's very important that clinicians be aware of that as a risk and do everything they can to minimize it.
Great. So speaking of side effects, there's also sialorrhea or excessive drooling. Maybe it doesn't sound as bad as some of the other side effects we've talked about, but I have had patients actually request to get off this medication because the sialorrhea was that bad. So I guess one, what are some ways we can combat this? Two, I was always curious myself why it caused sialorrhea, because that's a cholinergic side effect, whereas we were always taught that clozapine is the most anticholinergic of the antipsychotics. I think upon my reading as an intern, I was reading how it was the active metabolite, norclozapine, that is heavily procholinergic that causes a sialorrhea. And we're kind of touching on Cobenfy a lot, but I was also reading a study where they tested just norclozapine by itself, I believe, for schizophrenia. And I think the data wasn't all that effective, actually. So I'm just confused why now we have this new drug that's, perhaps very similar to norclozapine that is now approved.
Well, I think it's different. I mean, these are complicated phenomena, and I'm certainly not an expert on the muscarinic agonists, et cetera, et cetera. So it is counterintuitive. There's no question that it's a little puzzling why we see hypersalivation as such a salient adverse effect. But be that as it may, in terms of mechanism, it is a very real phenomena. It's one of the most frequent reasons for people wanting to discontinue clozapine, as you said. I mean, sedation is another one, weight gain is another one, but hypersalivation or sialorrhea is a very common reason. It's very troubling to patients. It's embarrassing. It's another potentially very serious side effect because it can lead to aspiration pneumonia, which is potentially fatal. So I think we need to take hypersalivation very seriously as an adverse effect for all of those reasons. And it affects most patients. The overwhelming majority of patients are going to have some degree of hypersalivation. So, in terms of all of these things, I guess I want to make sure that we emphasize that talking to our patients and monitoring for adverse effects is absolutely critical. And because clozapine has some potentially fatal adverse effects, it becomes even more important. As I said earlier, we've been forced to monitor for severe neutropenia, perhaps even more than is necessary, but we're not being forced in the same way to monitor for some of these other potentially lethal side effects. So it's very important that your colleagues understand that they need to evaluate their patients. They need to be talking to them. They need to be warning them about these things, guiding them as to what to look for, et cetera. So as far as sialorrhea, the treatments that are basically recommended are atropine drops, now sublingually. But botulinum toxin B injections have become, I think, a go-to treatment for a lot of patients with hypersalivation. So it's something that residents should identify a colleague in neurology or who is prepared to give such injections and consider that as a potential treatment. Yeah, it's certainly an adverse effect that needs to be addressed.
Cool. And I believe actually the botulinum toxin is a treatment for sialorrhea. That's now a PRITE question. Yeah, but kind of moving on, you mentioned it already many times how there's strict monitoring, no blood, no drug, right? So I did want to discuss the REMS protocol. Right now in the United States, I believe it's mandated that when you first start the medication for the first 6 months, it's required to get weekly blood work done. After that, the next 6 months, you need to get it done every 2 weeks. And then after that, even if you're on it for 30 years later, you still have to get it done monthly. And I think the initial intention was good. It was to maximize safety because there was that fear of agranulocytosis, neutropenia, things like that. But this strict monitoring schedule has caused some issues, such as delays in patients receiving medication sometimes, which can lead to retitration, relapse of symptoms, as well as things like provider and patient resistance to starting the medication in the first place. Recently, however, I think November of last year, the FDA Advisory Committee voted 14-1 to dismiss this REMS protocol, but I don't think anything's been made concrete yet. So I wanted to hear your thoughts on the REMS protocol and what you foresee happening in the future.
Sure. Yeah, I was fortunate to be at that meeting, to be one of the speakers, and to be able to listen to the discussion. As you said, it was two separate committees that were meeting together. The vote was 14-1. The one person who did not vote with the majority was basically not saying that we should preserve the REMS program in its current form. He was basically saying maybe we should consider having a REMS program for the first 6 months, but not after. But he certainly wasn't in major disagreement with the rest of the advisors. The FDA does not have to follow the advice of its committees. It usually does. So we haven't heard from them exactly what they're going to do and when. But this is not going to change the package labeling. So I think there's some confusion that people have at times. Is the REMS program what determines the frequency of the monitoring? No, the REMS program was really a requirement for reporting the results. And that was problematic for a lot of people. It wasn't always being adhered to. It did create some of the concerns that you raised a moment ago, but there's no indication that the FDA is going to change the package label. I think some of us would like to encourage a review of the label, and that it's probably not necessary to continue monitoring for severe neutropenia after, let's say, 2 years, if the patient's done well. The majority of the cases occur in the first 18 weeks. So it's understandable that we would want to monitor weekly for 18 weeks. After that, I think the yield declines. The risk, and some people have suggested that the risk of clozapine-induced severe neutropenia goes away. It doesn't really go away. It does diminish over time, but it does remain higher than what we see with other antipsychotic drugs. However, I think it does become low enough that to require continued monitoring is not really necessary. So, and given that, the context that we've talked about earlier of other adverse effects that actually are associated with a greater likelihood of fatality, we should be focusing more attention on some of those adverse effects. But as you said, the committees did vote. They recommended that the REMS program no longer be a requirement. So there was a lot of, I think a lot of people were very pleased to hear that recommendation.
Yeah, absolutely. I think that's an exciting development, and we're all looking forward to seeing what happens with that. One of the things that I've heard going through training, not even just as a resident, but also as a medical student, is candidates for those patients where you feel like, they may be a clozapine candidate, but then we hear that there's no long-acting injectable of this medication. And that always begs the question of medication adherence. So I'm wondering if you think, Dr. Kane, that there will ever be in the future a development of something like a clozapine long-acting injectable, or if you can speak to adherence, maybe anecdotally or just educationally, if this is a valid concern.
Sure. And I think adherence is always a valid concern. What's fascinating, though, about clozapine is we see higher adherence rates with clozapine, despite all of these problems that we've been talking about, the need for blood tests, et cetera, because patients, when clozapine is helpful, it's something that they personally recognize and appreciate. So they are much more interested and willing to take the medicine than they might with other medicines that are not working as well. So it would be great if we had a long-acting injectable formulation. I don't think that's likely. I wouldn't, one never rules things out in science, but I don't think it's likely in the near future. However, if somebody responds well to clozapine, they are likely to be adherent. That's the good news. The other thing that I'd want to emphasize is, since the publication of that paper that I mentioned in 1988, there have been many, many other studies of clozapine showing its advantages. For example, the reduction of suicidality. The FDA did approve that. So that is now in the package label, that clozapine can be used to reduce the risk of suicidality. In addition to that, clozapine has been shown to be better at preventing relapse. We just published a paper in Lancet Psychiatry within the last few weeks, showing from a large database in Scandinavia that for those patients who relapse, putting them back on the same drug is not very efficacious. That clozapine is more efficacious in preventing relapse and rehospitalization than other medicines. So one question is, when somebody relapses, particularly if they've been taking their medicine, is that a form of treatment resistance? We haven't considered it as such, but it may be if somebody breaks through medication. We've been doing studies, for example, of patients who are receiving long-acting injectable medications. We know that they're getting their medicine. It's not confounded by non-adherence. And we're trying to understand, why do those patients relapse? They clearly have adequate dopamine receptor antagonism, but they're relapsing. So that may be a form for us of treatment resistance. And I think these data coming out of Scandinavia reinforce that. The other thing that we've seen is clozapine can be particularly helpful in reducing aggressive and violent behavior. We mentioned earlier the studies of mortality, that patients taking clozapine are surviving longer than patients not taking clozapine. So it has some very interesting characteristics. Unfortunately, we can't predict who's going to respond to clozapine. And I think it's really a shame if somebody for whom clozapine is indicated doesn't get a trial. Right now in the U.S., the estimates, and this was presented at the FDA advisory committee, the estimates are that only 1 out of 8 patients who should get a trial of clozapine is actually getting a trial of clozapine. And we're basing that on the prevalence of treatment-resistant schizophrenia, which may be as high as 40% when you follow people over time. Even in the very first episode of schizophrenia, about 20% are treatment-resistant, meaning they fail to respond to 2 trials of 2 different antipsychotic drugs. Those patients should get a trial of clozapine, and by and large, they are not. So there's really an 8-fold gap in the utilization of clozapine, and we could talk a lot about the reasons for that. Some people blame the REMS program. I think that was a minor obstacle. I don't think it was a major obstacle. But we don't have good predictors of clozapine response. We know that about half of the patients will have a clinically meaningful response, and a smaller subgroup will have a potentially life-changing response. And it's unfortunate if patients don't have the opportunity to see that. And what we tell patients and families is we can't predict how you or how your loved one is going to respond to clozapine. The only way we're going to know is if we do a therapeutic trial, which means that you need to take this medicine for a few months and see how you do. That will then give you an opportunity to make an informed decision as to whether the benefits outweigh the risks. You will also have had the opportunity to see what side effects you might experience from clozapine, and then you can have a balanced view to make an informed decision. Without that experience, without that trial, it's totally abstract. And I think that's a very important message to get across to patients and families. We really have to increase the utilization of clozapine until we find something that works as well, which I hope we do. But right now, it's the best that we have. And it's a shame. I mean, this is true in medicine in general. We see that evidence-based practice is not always implemented. I think it's important for your colleagues also to be part of the solution. And what we've seen is that if you don't have experience using clozapine as a resident, there's a good chance you won't feel comfortable doing it later on in your career. So I think the training component is very important. And I think those of you who are working in programs that don't have that opportunity should try to ask your training directors to make sure that you get that experience.
Yeah, and I like to call that colloquial medicine, actually. So that's my term for non-evidence-based practices. But as a last question, we already talked about it a bunch, but where do you see Cobenfy or xanomeline trospium in the pantheon of antipsychotics? And also, where do you see the future of treatment for schizophrenia? Because there's another drug, I believe, Eulodurant. It's a TAR1 agonist. It looked promising, but ended up failing the phase 3 trials. The pharmacology looks pretty rich, though. Do you see future developments for non-dopamine blockers for the treatment of schizophrenia?
Yeah, well, I think xanomeline trospium is certainly a success story. I think they did very good trials. They got approval. It's a different mechanism of action. They have a different label, if you will, different no boxed warnings in that sense. So that's very good news. That's very exciting. I think that's led to a lot of enthusiasm in CNS drug development. However, as you said, the TAR1 compound looked very promising, but then failed. We still struggle with placebo response, and so when we see these failed trials, or in this case, a negative trial, and let me just point out what the difference is. When we compare a new medicine to placebo and it is not superior to placebo, that's a negative trial. When we have a third arm of an approved effective medication, we have that to ensure the validity of the study. Was this a patient population that's capable of responding to medication, et cetera, et cetera. So you have the experimental drug, you have an active control drug that's already approved, and then you have placebo. If the approved medication doesn't beat placebo, that's a failed study. That means there's something wrong with the study itself. Why did this drug that usually works not work in that particular context? So what we saw with the TAR1 agent was a negative study. And, that was disappointing because their previous study had been positive. We also saw a negative study with emraclidine, which was a muscarinic M4 agent, and that was disappointing. The company that sponsored those studies was purchased by a larger pharmaceutical company, and then this negative studies came out. In addition, within the last few weeks, we had an announcement by Boehringer Ingelheim that their agent, which was being developed for the treatment of cognitive dysfunction and schizophrenia, also failed to replicate the earlier positive study that they had seen. So we've had a number of disappointments along with the excitement that we've seen with xanolamine. There are several other muscarinic agonists under development. So in all likelihood, we will see some further progress in that arena, but it's going to take years. There is, I think there is hope for new mechanisms of action, but as we've seen, it's complicated. The trials are challenging, often because of placebo response that is much higher than anticipated. So we have, we definitely have work to do, but there's reason for optimism. I must say, though, that what troubles me more is the lack of our ability to use the medicines that we have now in the most judicious way. I mean, we talked about the underutilization of Clozapine. We could also talk about the underutilization of long-acting injectable medicines, which have many advantages, but are also grossly underutilized. We still see patients not receiving any medication at all, and as a result, having a psychotic relapse. We have patients who are struggling with side effects that could be better managed. I mean, so we have a lot of things that we could be doing better while we wait for newer medicines. But I'm optimistic that, over time there will be newer medicines, different mechanisms of action. But schizophrenia is a tough illness. We still don't have anything approved for negative symptoms. We still don't have anything approved for cognitive dysfunction. And these are the major drivers of functional impairment.
So, Dr. Kane, before we wrap up, any last points that you wanted to raise or anything like that?
I guess just to you and your colleagues, the future is in your hands. Make sure you try to keep up with recent advances, and I would say be careful to what you pay attention, because there are so many demands on your attention now that you do have to be careful with that. But keep up with your reading, keep up with the literature. Make sure that you're implementing evidence-based practice whenever possible. Make sure that you're teaching your patients and their families, in a way that's going to ultimately be helpful to them. It's a tough illness. Also, I hope that people will continue to work with underserved populations and spend some time in that arena, regardless of what else you're doing. So, but thank you for the opportunity.
All right, so I think that just about brings today's episode to a close. I want to sincerely thank Dr. John Kane for agreeing to come on today and recording with us. One thing I did want to mention, for those of you looking for some resources or anything like that about Clozapine, one of my favorites was Dr. Stephen Stahl and Dr. Jonathan Mayer's resource, which is the Clozapine Handbook with his Cambridge series. We do not receive any sponsorship or anything like that for these products, but it's worth a read. As always, feel free to contact us at psychroundspodcast@gmail.com for questions, comments, or future episode suggestions. If you're a fan of the podcast, please drop us a follow, rating, review, as this helps us reach larger audiences. We will see you next time and have a great weekend.